Respetables profesionales, tengan todos buenas tardes. Se les saluda desde las diferentes dependencias del Ministerio de Salud y del Sistema Nacional Integrado de Salud, que cada miércoles siempre están presentes y pendientes de estos webinarios del Instituto Nacional de Salud. Sean todos bienvenidos. Estamos en el desarrollo del módulo de webinarios de Cardiología Perinatal con el propósito de sumar conocimientos que permitan fortalecernos como comunidad de práctica para mejorar la atención en salud de las pacientes embarazadas con cardiopatías y mejorar la esperanza de vida de los niños con cardiopatías congénitas. El webinario de hoy es sobre los factores de riesgo modificables para prevenir la enfermedad cardiovascular en la embarazada. Este tema, que es especialmente importante, nos ayudará a tomar en cuenta aspectos a fortalecer para la prevención de las enfermedades cardiovasculares, considerando directrices para la evaluación y la identificación oportuna y el abordaje de los factores de riesgo cardiovascular, lo que con seguridad se va a traducir en menos complicaciones y menos mortalidad por cardiopatía. Ya ustedes conocieron a nuestra invitada especial, la doctora Sara Lisa Goldstein, quien nos impartió el webinario anterior. Ella es cardióloga especializada en el cuidado de adultos con enfermedades cardíacas o adquiridas que afectan el embarazo. Es especializada en cardio-obstetricia y tiene colaboraciones multidisciplinarias tanto en la atención clínica como en la investigación. Es profesora asistente de cardiología en la Facultad de Medicina de la Universidad de Yale. Es fellow de investigación sobre cardiopatías congénitas en adultos y enfermedades cardiovasculares del Centro Médico de la Universidad de Yale, de la Universidad de Duke, en el año 2020 y 2022. Es investigadora, también ha generado insumos para mejorar la efectividad de la consejería preconcepcional para pacientes con enfermedades cardíacas complejas. La doctora Goldstein es una persona que ha dedicado parte de su tiempo para enseñarnos a nosotros acá. Le agradezco su disposición, doctora, por compartir con profesionales salvadoreños a través del Instituto Nacional de Salud. Nos apoyará en la traducción simultánea el doctor Paolo Vigni. Para traducción, a quien le agradezco mucho su buena disposición y su ayuda. Y saludo al doctor Robert McNamara, que nos está escuchando y viendo en este momento, a quien agradezco también todos los enlaces que hacen posible compartir con la Universidad de Yale. Le cedo el espacio, doctora Goldstein, sea bienvenida.
Muchas gracias por tenerme aquí de nuevo. Ahora vamos a estar hablando de la interacción entre el embarazo y la enfermedad cardiovascular, sobre todo sus factores de riesgo y el impacto de esta.
During this lecture, we'll review contemporary pregnancy outcomes and the effect of acquired heart disease on these outcomes. We'll describe the impact of pre-existing cardiovascular risk factors on pregnancy outcomes. We'll review the most common pregnancy-associated cardiovascular conditions and whether there are certain preconception interventions that may reduce adverse cardiovascular outcomes related to these conditions. And finally, we'll discuss the implications of pregnancy complications on future cardiovascular disease and propose strategies to optimize long-term cardiovascular health among women who experience pregnancy complications. Over the past few decades, pregnancy outcomes and cardiovascular disease complicating pregnancy have received significant attention among the medical profession as well as in mainstream media in the United States. This figure from the U.S. National Center for Health Statistics demonstrates that over the past 30 years, the United States is the only developed country in the world in which maternal mortality is rising. In 2015, maternal mortality in the U.S. was almost 3 times as high as the next worst country. This trend has continued to worsen since that time and has been mirrored by maternal morbidity. Over that same time period, there has been a shift from traditional pregnancy complications such as hemorrhage and infection as the primary cause of morbidity and mortality. Instead, cardiovascular disease is now the leading cause of death related to pregnancy in the United States, accounting for around 45% of all maternal mortality. As a result of this, there has been significant attention paid to targeted research efforts to improve care delivery for patients with pre-existing cardiovascular disease, as well as those considered at high risk for cardiovascular disease complicating pregnancy. To do this, it was first important to understand the reason behind these worsening outcomes. The cause is likely multifactorial. The American Heart Association released an expert opinion statement in 2020, highlighting a few major contributing factors. First, owing to improved pediatric medical and surgical outcomes, there has been a growing number of patients with congenital heart disease surviving to childbearing age who are healthy enough to consider pregnancy. Due to a relatively low prevalence of congenital heart disease in the general population, however, this is felt to explain only a small proportion of the observed cardiovascular disease burden affecting pregnancy. What instead accounts for the majority of pregnancy-associated cardiovascular adverse outcomes is acquired heart disease. Women are experiencing their first gestation at older ages. Older age at the time of pregnancy is associated with an increased prevalence of cardiovascular comorbidities and resulting acquired heart disease. Additionally, in the US, women are developing cardiovascular risk factors at younger ages, and thus the burden of cardiovascular comorbidities and acquired heart disease among pregnant patients and patients of childbearing age is increasing. So what is it about pregnancy that puts patients with cardiovascular disease or cardiovascular risk factors at risk? Pregnancy can be poorly tolerated among these patients due to the profound and dynamic physiologic changes needed to support adequate utero-placental blood flow while maintaining maternal circulation. These physiologic adaptations can lead to decompensation among patients with pre-existing disease and can also uncover previously undiagnosed cardiovascular disease or even trigger the development of new disease in predisposed patients. During pregnancy, cardiac output must increase up to 50% above pre-pregnancy levels. Cardiac output begins to increase in the first trimester and peaks around 26 weeks of gestation. To enable this, there is a 30 to 40% decrease in vascular resistance, a 10 to 20% increase in heart rate, and around a 40% increase in circulating blood volume, the last of which peaks in the third trimester. Patients also develop a relative anemia due to inadequate augmentation of red blood cell mass compared with plasma volume. Further hemodynamic changes occur in the postpartum period. Immediately after delivery, systemic and pulmonary vascular resistance rapidly rise following the delivery of the low-resistance placenta. Additionally, fluid shifts lead to further increase in circulating blood volume and cardiac output. It can typically take around 6 weeks, or in some cases, even longer, for pregnancy hemodynamics to resolve back to baseline. Pregnancy is also a prothrombotic state. Pregnant patients are at around a 5-fold increased risk for thrombotic complications, with risk for thrombosis remaining elevated for up to 3 months postpartum. Finally, pregnancy is also associated with an increased risk of arterial dissection, including aortic dissection as well as spontaneous coronary artery dissection. This risk is thought to be related to a combination of hemodynamic and hormonal changes. Predicting which patients are at elevated risk for cardiovascular complications during pregnancy can be complicated. There are multiple risk assessment tools that can be applied to patients with pre-existing cardiovascular disease, including the modified WHO classification system, CARPREG-2, and the Zahara risk assessment tool, all of which we discussed during our lecture last week about adult congenital heart disease management during pregnancy. Unfortunately, for patients with cardiovascular risk factors who do not have a cardiac diagnosis prior to conception, there are no currently available preconception risk assessment tools validated to predict the risk of new cardiovascular disease during pregnancy. What we do know, and what can be used to help counsel patients in the preconception period, is that the presence of pre-pregnancy cardiovascular risk factors is associated with adverse pregnancy outcomes, including maternal intensive care unit admission, preterm birth, having a low birth weight infant, and fetal death. Furthermore, the association of each adverse outcome is stronger with greater risk factor burden when compared with those without pre-pregnancy cardiovascular risk factors. Although not yet included in guidelines, many patients are screened for these risk factors by their providers when they start to consider pregnancy. Among those with cardiovascular risk factors without pre-existing cardiovascular disease, new cardiovascular disease during pregnancy is a major driver of the observed adverse pregnancy outcomes. The most common cardiovascular complications include hypertensive disorders of pregnancy, cardiomyopathy and heart failure, arrhythmias, and ischemic heart disease. Now we will briefly review each of these cardiovascular complications of pregnancy and their relationship to pre-pregnancy cardiovascular risk factors. Hypertensive disorders of pregnancy are a group of diagnoses that typically involve new onset hypertension, defined as a systolic blood pressure of greater than or equal to 140, or diastolic blood pressure greater than or equal to 90, on 2 occasions after 20 weeks of gestation, more than 4 hours apart. There can be variable timing of presentation, with 85% of patients presenting between 34 weeks of gestation and delivery, 10% at less than 34 weeks, and 5% in the postpartum period. Patients remain at risk for hypertensive disorders of pregnancy for up to 6 weeks after delivery. Hypertensive disorders of pregnancy represent a continuum of disease severity and associated risk, ranging from the lowest risk gestational hypertension through the highest risk conditions, HELLP syndrome and eclampsia. Gestational hypertension is defined as new onset hypertension alone. Preeclampsia is new onset hypertension with new proteinuria. Preeclampsia with severe features is defined as new hypertension with at least one clinical feature that indicates elevated risk. Potential qualifying high-risk features include severe range blood pressure above or equal to 160/110, acute kidney injury, elevated transaminases, right upper quadrant pain, neurologic symptoms, thrombocytopenia, and pulmonary edema. There may or may not also be proteinuria in the setting of preeclampsia with severe features. HELP syndrome is characterized by the presence of hemolysis, elevated liver enzymes, and low platelets. And finally, eclampsia is diagnosed in the presence of new tonic-clonic seizures. Hypertensive disorders of pregnancy are a leading cause of maternal and perinatal mortality worldwide. Importantly, hypertensive disorders of pregnancy do not always progress in a linear fashion from least severe to most severe. Only 50% of patients who develop gestational hypertension progress to having a more severe disorder. But when there is progression, the rate of that progression can be variable and unpredictable. Additionally, 1/3 of patients with eclampsia present with normal blood pressure and no preceding symptoms. The pathophysiology of hypertensive disorders of pregnancy remains incompletely understood, but it seems to be related to a pathogenic process that affects the vasculature of the placenta that occurs in the presence of a wide variety of risk factors. There are many potential risk factors for hypertensive disorders of pregnancy that have been identified. Some are not modifiable, including nulliparity, multifetal gestation, preeclampsia complicating a prior pregnancy, renal disease, thrombophilia, autoimmune disease, advanced maternal age, the use of assistive reproductive technology, family history of preeclampsia in a mother or sister, and the presence of certain types of congenital heart disease. Some risk factors are modifiable and are notably more traditional cardiovascular risk factors, including hypertension predating pregnancy, pre-gestational diabetes, obesity, hyperlipidemia, sleep apnea, and physical inactivity. After hypertensive disorders, heart failure is the most common cardiovascular complication of pregnancy and is associated with severe outcomes. The rate of heart failure in pregnancy has been increasing. Patients with pregnancy-associated heart failure most commonly present in the postpartum period and least commonly present during the delivery admission. Peripartum cardiomyopathy is the most common cause of new cardiomyopathy and heart failure with reduced ejection fraction among pregnant patients. It's diagnosed in patients with new idiopathic cardiomyopathy with reduced ejection fraction of less than 45% who are presenting towards the end of pregnancy or within 5 months postpartum. Patients must have clinical heart failure symptoms to qualify for this diagnosis. The incidence of peripartum cardiomyopathy varies significantly by geographic region, suggesting that there is likely an underlying genetic etiology. It's most common in certain areas of Africa and least common in Asian countries. In the United States, the incidence of peripartum cardiomyopathy has been rising, likely related to rising maternal age, increasing cardiovascular comorbidity burden, increased rates of multifetal pregnancies due to the more frequent use of assisted reproductive technologies, and increased recognition of the disease. Peripartum cardiomyopathy can be difficult to diagnose due to an overlap between normal pregnancy symptoms and symptoms of heart failure, and thus sometimes presenting symptoms can be overlooked. Specifically, dyspnea, orthopnea, edema, and elevated JVP can result from normal pregnancy physiology, but could also be representative of decompensated heart failure. Unfortunately, 50% of patients diagnosed with peripartum cardiomyopathy present with a major adverse outcome preceding the diagnosis. Peripartum cardiomyopathy is associated with a mortality rate of 4 to 11%, which is quite high when compared to the mortality rate observed among the general population of women of childbearing age. That being said, the rate of left ventricular ejection fraction recovery in peripartum cardiomyopathy is much higher than that typically seen in other kinds of non-ischemic cardiomyopathy. Around 75% of patients experience left ventricular ejection fraction recovery by 12 months postpartum. Of note, patients who develop peripartum cardiomyopathy in the setting of a hypertensive disorder of pregnancy experience lower one-year survival, but higher rates of left ventricular ejection fraction recovery among survivors. The pathophysiology of peripartum cardiomyopathy is complex, multifactorial, and poorly understood. Mouse models have suggested that peripartum cardiomyopathy is primarily a vascular disease, triggered by the hormonal milieu of pregnancy and the postpartum period. Animal models have suggested that a genetic predisposition and certain risk factors lead to a susceptibility for myocardial damage in the presence of a specific prolactin breakdown product, a hormone involved in lactation. Similar to what is observed among patients with hypertensive disorders of pregnancy, a multitude of clinical factors associated with increased risk for peripartum cardiomyopathy have been identified. Some risk factors cannot be easily modified, such as multigravidity, multifetal pregnancy, advanced maternal age, underlying genetics, and use of tocolytic agents. Other risk factors are potentially modifiable, including hypertension, insulin resistance or pregestational diabetes, obesity, malnutrition, and drug and tobacco use. Another common form of heart failure associated with pregnancy occurs in the absence of reduced ejection fraction. Pregnancy-associated heart failure with preserved ejection fraction is defined as signs and/or symptoms of pulmonary congestion with or without evidence of systemic congestion occurring towards the end of pregnancy or within a few weeks after delivery in the setting of normal left ventricular function. Of note, patients with pregnancy-associated heart failure with preserved ejection fraction may or may not have left ventricular hypertrophy or diastolic dysfunction on transthoracic echocardiogram. The prevalence of pregnancy-associated heart failure with preserved ejection fraction has been increasing over time, mirroring the observed increased prevalence of chronic hypertension and hypertensive disorders of pregnancy. Hypertension, a modifiable risk factor, is by far the most strongly associated with the development of pregnancy-associated heart failure with preserved ejection fraction. Other associated clinical factors include pregestational diabetes, obesity, anemia, chronic kidney disease, and atherosclerotic coronary artery disease. Arrhythmia is another common cardiovascular complication of pregnancy. Much like heart failure, the burden of arrhythmia complicating pregnancy has also been increasing over time, owing primarily to increasing burden of atrial fibrillation and ventricular tachycardia. Hospitalization for arrhythmia during pregnancy is associated with significant adverse outcomes, including elevated rates of all-cause mortality, maternal morbidity, and fetal complications. The highest risk for maternal mortality is seen among those hospitalized for ventricular tachycardia, but rates of non-fatal maternal complications and fetal complications are elevated almost equitably across all arrhythmia types. Pregnancy is known to be associated with an increased incidence of arrhythmias. Increased circulating blood volume resulting in atrial and ventricular stretch and chamber enlargement, hormonal changes, increased sympathetic tone, and increased chronotropy all contribute to pregnancy being a pro-arrhythmic state. The strongest non-modifiable risk factor for arrhythmia during pregnancy is history of arrhythmia, but advanced maternal age, socioeconomic status, and use of tocolytic agents are also associated with elevated risk. Modifiable risk factors for arrhythmia include hypertension, pregestational diabetes, obesity, and drug use. Of note, chronic hypertension and hypertensive disorders of pregnancy are particularly associated with atrial fibrillation, which is the most common arrhythmic cause for hospitalization during pregnancy. Finally, pregnant patients are at a four-fold increased risk for acute myocardial infarction compared with non-pregnant reproductive aged patients. Although this complication remains rare, the incidence is increasing, and pregnancy-associated myocardial infarction is associated with particularly poor outcomes. Pregnancy-associated myocardial infarction underlies greater than 20% of maternal deaths related to cardiovascular disease and carries a 5% case fatality rate. The risk of myocardial infarction is thought to be elevated during pregnancy, related to the combination of pregnancy-related hemodynamic changes, hormonal changes, and hypercoagulability. Pregnancy-associated spontaneous coronary artery dissection is the most common cause of acute myocardial infarction during pregnancy, accounting for greater than 40 to 50% of all cases. Other causes of myocardial infarction during pregnancy include atherosclerotic coronary artery disease, coronary vasospasm, and coronary artery embolism. Outcomes after pregnancy-associated spontaneous coronary artery dissection are particularly poor due to a more severe disease course. Patients with pregnancy-associated spontaneous coronary artery dissection are more likely to have left main and proximal left anterior descending artery involvement than is observed in other causes of pregnancy-associated myocardial infarction, as well as spontaneous coronary artery dissection occurring outside of pregnancy. Non-modifiable risk factors for pregnancy-associated myocardial infarction include advanced maternal age, multiple gestation pregnancy, hemorrhage requiring transfusion, postpartum infection, and pre-existing coronary artery disease. Risk factors specific to spontaneous coronary artery dissection include underlying predisposing disorders such as connective tissue disorders and fibromuscular dysplasia. Modifiable risk factors include hypertension, diabetes, obesity, hyperlipidemia, and tobacco use. Now that we've reviewed the most common acquired cardiovascular conditions complicating pregnancy, we have identified a common theme. Hypertension, diabetes, and obesity have been identified as modifiable risk factors for all of these common cardiovascular adverse outcomes. So, what are the recommendations for the management of these risk factors before and during pregnancy to reduce the risk of cardiovascular complications? Chronic hypertension is common among women of childbearing age, affecting 13% of those aged 20 to 34 and 30% of those aged 35 to 44 in the United States. Unfortunately, for many patients of childbearing age, blood pressure control is poor. In the US, only 16% of reproductive aged women with chronic hypertension achieve a blood pressure goal of less than 130/80. Uncontrolled chronic hypertension prior to pregnancy is more strongly associated with adverse cardiovascular outcomes when compared with achievement of goal blood pressure. To optimize blood pressure control during pregnancy, it is recommended that management begin prior to conception. Achieving goal blood pressure on a pregnancy-safe medication regimen prior to conception should be a priority. When selecting a medication regimen, nifedipine and labetalol are considered first-line therapies. Hydrochlorothiazide, amlodipine, and hydralazine are also considered safe to use during pregnancy, but there is less safety data available, so they are not considered first line. If, however, a patient with chronic hypertension is stable on one of these medications prior to pregnancy, it is reasonable to continue this regimen without interruption. There is extensive data supporting the safety of methyl-dopa during pregnancy, but it is not as effective as other options and therefore not preferred. Importantly, patients should demonstrate clinical stability on the medication regimen that will be used during pregnancy for a number of months prior to conception to optimize their chances of achieving adequate blood pressure control during pregnancy. For patients with chronic hypertension who are considering pregnancy, it is also important to obtain baseline testing during the preconception period so that cardiovascular complications can be more easily diagnosed and risk for complications can be assessed. Renal function should be evaluated in all patients with chronic hypertension, as chronic kidney disease further increases the risk for resistant hypertension during pregnancy and the development of preeclampsia and related disorders. Urine protein creatinine ratio should also be assessed, as it can be difficult to diagnose preeclampsia if baseline proteinuria is unknown. Pro-BNP assessment should be considered in all patients to establish a baseline. Pro-BNP can then be utilized during pregnancy as needed based on symptoms, with a dramatic increase in pro-BNP levels compared to pre-pregnancy, suggestive of new heart failure as the cause of symptoms, as opposed to normal physiologic changes of pregnancy. In patients with a long-standing history of poorly controlled hypertension, preconception transthoracic echocardiogram should be considered to rule out ventricular dysfunction, which would place patients at a much higher risk for cardiovascular complication during pregnancy. Additionally, the presence of left ventricular hypertrophy or left atrial enlargement on echocardiogram may indicate a higher risk for pregnancy-associated heart failure with preserved ejection fraction and/or atrial fibrillation. Finally, patients should be asked about chest pain, and there should be a low threshold for stress testing prior to conception to evaluate for previously undiagnosed coronary artery disease. There has recently been a paradigm shift in the management of chronic hypertension after conception. Traditionally, it had been recommended to treat chronic hypertension during pregnancy to a goal blood pressure of less than 160 over 105, as it was believed that further lowering of blood pressure may affect placental perfusion and lead to adverse fetal and neonatal outcomes. A recent study, however, compared a treatment goal of 140 over 90 to the traditional goal of 160 over 105. This study found that there was no difference in fetal growth, but that there were better maternal clinical outcomes in the group with tighter blood pressure control. Because of this, the American College of Obstetrics and Gynecology recently updated their guidelines accordingly, and treatment to a goal of less than 140 over 90 is now recommended for patients with chronic hypertension. As such, this should be the treatment goal prior to conception when attempting to stabilize a patient on a pregnancy-safe medication regimen. It's additionally recommended that patients with chronic hypertension take aspirin 81 milligrams daily beginning at 12 weeks of gestation, as this has been associated with a reduced risk of preeclampsia and associated adverse outcomes in high-risk patients. Pregestational diabetes is less common than chronic hypertension, affecting 3 to 7% of women of childbearing age. Cardiovascular complications during pregnancy are more common among those with long-standing disease, particularly if poorly controlled, and those who also have chronic hypertension. There are no definitive data or recommendations for the management of diabetes before and during pregnancy focused on the goal to optimize cardiovascular outcomes. In general, achievement of a hemoglobin A1C level of less than 6.5% is recommended prior to conception. Medication optimization is also recommended. Metformin can be safely continued during pregnancy among patients who are on this medication chronically. All other oral agents are not considered safe in pregnancy and should be discontinued. Insulin should be started if necessary to achieve the goal hemoglobin A1C. Regular aerobic exercise and dietary interventions are associated with improved glucose control during pregnancy. These lifestyle modifications should be implemented before pregnancy so that they can be habitual by the time a patient conceives. Pregestational diabetes is also associated with many obstetrical, fetal, and neonatal complications. It is therefore recommended that these patients have a preconception consultation with a high-risk obstetrician. During pregnancy, a hemoglobin A1C of less than 6.5% is targeted during the first trimester and less than 6% during the second and third trimester. These recommendations are aimed at optimizing fetal and maternal non-cardiac outcomes, and it remains unknown if optimal blood glucose control during pregnancy affects pregnancy-associated cardiovascular outcomes. Obesity is extremely common in the United States. In the US, 40% of all women of childbearing age have a BMI consistent with obesity. Among obese patients, the risk for cardiovascular complications during pregnancy is highest among those who also have obstructive sleep apnea, particularly if the obstructive sleep apnea is untreated. To optimize pregnancy outcomes among obese patients, weight loss should be pursued prior to pregnancy, either through surgical or non-surgical methods. Based on guidelines, a normal BMI prior to pregnancy should be the goal, but even a 5 to 7% weight loss prior to conception is associated with lower rates of pregnancy adverse outcomes. Although helpful in achieving these goals, weight management medications should not be used in the immediate preconception or antepartum periods due to concerns about fetal adverse effects. Instead, during pregnancy, weight management strategies focus on optimization of diet and regular exercise. Almost all patients gain weight during pregnancy, but recommended weight gain targets should be adjusted based on pre-pregnancy BMI. For patients who are obese, weight gain of no more than 20 pounds is recommended, with a rate of weight gain in the second and third trimester no more than 0.5 pound per week. Importantly, these recommendations are aimed at improving overall pregnancy outcomes, not specifically cardiovascular complications. It is unknown if the chronicity of obesity or if obtaining a normal BMI prior to pregnancy after being obese affects the associated cardiovascular disease risk in pregnancy. It has been shown, however, that treatment of sleep apnea can reduce the risk of cardiovascular complications. It's therefore recommended that obese patients be evaluated for sleep apnea prior to pregnancy and be on appropriate treatment prior to conception. It's safe and advisable to continue CPAP during pregnancy to reduce cardiovascular adverse outcomes. Although hyperlipidemia was not a common risk factor among all of the acquired heart diseases that we discussed, it is associated with increased risk for the development of hypertensive disorders of pregnancy and pregnancy-associated acute myocardial infarction. Treatment goals and optimal management of hyperlipidemia before and during pregnancy is not addressed in guidelines due to a paucity of data to support recommendations. It is known that lipid levels increase significantly during pregnancy, but the clinical significance of this, particularly among those with pre-existing hyperlipidemia, on cardiovascular outcomes is unknown. Management for most reproductive age patients with hyperlipidemia focuses on diet and lifestyle interventions. Among patients under the age of 40, medical therapy is only recommended for those with severe LDL elevation. Currently, bile acid sequestrants are the only class of lipid-lowering medication that is approved for use during pregnancy without significant concern for fetal effects. Traditionally, statins have been considered contraindicated during pregnancy due to animal models and human case series reporting associated teratogenicity. Current recommendations are to discontinue statin therapy at least 3 months prior to conception and not resume during pregnancy. There is now emerging data, however, that hydrophilic statins, such as rosuvastatin and pravastatin, do not readily cross the placenta and therefore do not pose significant fetal risk. As such, the Food and Drug Administration removed the black box warning for the use of statins during pregnancy in 2022. In most cases, however, statin therapy during pregnancy continues to be reserved for secondary prevention and for patients with familial hyperlipidemia. In addition to the effect of cardiovascular risk factors on pregnancy-associated cardiovascular disease, adverse pregnancy outcomes specific to pregnancy in themselves also have a significant impact on the cardiovascular health of women. Relevant adverse pregnancy outcomes include hypertensive disorders of pregnancy, spontaneous preterm birth, and fetal intrauterine growth restriction, all of which are increasing over time in prevalence. Although the exact pathophysiology is uncertain, adverse pregnancy outcomes are believed to be caused by similar underlying metabolic or vascular abnormalities and originate with defective or abnormal placental vascular development. This leads to release of pro-inflammatory proteins and in turn causes maternal vascular dysfunction. Patients who experience a pregnancy complicated by an adverse pregnancy outcome are at about a 4-fold increased risk for future cardiovascular disease later in life. This includes a relative risk of around 2 for cardiovascular death, coronary artery disease, and stroke, and a relative risk of around 4 for chronic hypertension and heart failure. The pathophysiology of the association between adverse pregnancy outcomes and future cardiovascular disease remains incompletely understood. Adverse pregnancy outcomes are associated with cardiovascular maladaptations, such as abnormal cardiac mechanics, coronary endothelial dysfunction, and loss of arterial compliance, all of which can persist into the postpartum period. Additionally, adverse pregnancy outcomes and cardiovascular disease unrelated to pregnancy share similar genetics, pathophysiology, and risk factors. As we have previously discussed, cardiovascular risk factor burden is associated with risk for adverse pregnancy outcomes. It is therefore hypothesized that the association of adverse pregnancy outcomes with future cardiovascular health in women is related to a combination of resulting changes in the cardiovascular system as well as shared risk factors. It's also hypothesized that this risk can be modulated through lifestyle interventions and modifiable risk factor optimization. Guidelines recommend that all patients undergo cardiovascular risk factor assessment and receive diet and lifestyle intervention counseling within the first year postpartum after experiencing an adverse pregnancy outcome. Despite this, less than 1/3 of patients undergo blood pressure assessment and/or cardiometabolic risk factor testing within the first year. Although we as cardiologists are generally not directly involved in the acute management of adverse pregnancy outcomes, the development of clinical programs that include cardiology expertise and are dedicated to the postpartum management of adverse pregnancy outcomes to optimize future cardiovascular health are becoming more common. It is now suggested that the development of an adverse pregnancy outcome, particularly if it is a hypertensive disorder of pregnancy, be viewed as a red flag that indicates that a patient may be at increased risk for cardiovascular disease and would benefit from early risk factor assessment and modification. This should prompt referral to cardiology for formal cardiovascular risk factor assessment in the first year postpartum, with interventions to mitigate risk related to modifiable risk factors during that time. Optimal risk mitigation strategies specific to adverse pregnancy outcomes as risk factors have not been established. It's therefore recommended that management be focused on assessment of shared cardiometabolic risk factors, optimization of those risk factors, and lifestyle interventions. One important intervention is patient education. It's imperative that patients be made aware of the association of their pregnancy complication with their future health, as this helps empower them to make positive lifestyle changes and seek appropriate long-term follow-up care. Other important interventions to pursue in the first postpartum year include blood pressure surveillance and management, cardiometabolic assessment and treatment as indicated with lipid panel, hemoglobin A1C, and lipoprotein(a), implementation of weight loss and exercise programs, and a focus on smoking cessation if applicable. So in conclusion, maternal morbidity and mortality are increasing, and this is primarily driven by a rising burden of acquired cardiovascular disease. The most common acquired heart diseases complicating pregnancy are hypertensive disorders, cardiomyopathy and heart failure, arrhythmias, and ischemic heart disease. Important modifiable risk factors for acquired heart disease during pregnancy include hypertension, diabetes, obesity, and hyperlipidemia. There remains a paucity of data and recommendations describing how best to optimize risk factors to lower the risk of acquired cardiovascular disease and resulting complications during pregnancy. Adverse pregnancy outcomes, including hypertensive disorders of pregnancy, preterm birth, and fetal growth restriction, are associated with an increased risk of future cardiovascular disease. Mitigation of future cardiovascular disease risk following adverse pregnancy outcomes is focused on cardiovascular risk factor assessment and modification, as well as lifestyle interventions within the first year postpartum and continuing throughout the adult lifespan. Future research is needed to identify cardiovascular risk mitigation strategies specific to adverse pregnancy outcomes. Thank you for your time.
Thank you, doctor. Right now, I'm going to see what are the questions that the public has given.
Nos han hecho a través del chat. La primera pregunta es un caso, una paciente embarazada con 28 semanas de gestación llega con taquicardia supraventricular y le colocan adenosina intravenosa. ¿Cuál sería la indicación para evacuar el bebé?
The first question is more of a case. A patient who is 28 weeks pregnant arrives with a supraventricular tachycardia and is given IV adenosine. What will be the indication to evacuate the baby, to deliver the baby, basically?
Yeah, that's a really good question. So in general, supraventricular tachycardias are hemodynamically tolerated during pregnancy and are actually rarely an indication for early admission, or early delivery. As long as there was no maternal hypotension for a prolonged period of time, in general, the fetus is unaffected by the supraventricular tachycardia. Adenosine is safe to use during pregnancy, and typically after adenosine is used, it's recommended to start a beta blocker to try and reduce the risk of recurrent supraventricular tachycardia during the duration of pregnancy. There should be certain precautions taken at the time of delivery, so those patients should be monitored closely for recurrent arrhythmia. The anesthesiologist should be aware of this patient's history so that adenosine can be readily available. And in rare cases, patients with recurrent supraventricular tachycardia during labor may require an assisted second stage of labor to avoid the effort needed for Valsalva.
Un bebé prematuro de 32 semanas hace 2 años. Embarazo actual con 30 semanas. Diabetes no controlada y con amenaza de parto prematuro. ¿Puede recibir esteroides antinatales para maduración pulmonar?
So, okay, we have a cardiopathic mother with ductus arteriosus with her second pregnancy. She has a history of first pregnancy with a premature baby of 32 weeks 2 years ago. Current pregnancy at 30 weeks, uncontrolled diabetes, high glycemia, and treat of preterm birth. So the question is, can I give antenatal steroids for lung maturation?
So I am going to need to defer that question to an obstetrical colleague. That's more of a question specific for the obstetricians as opposed to me as a cardiologist. The only time from a cardiologist perspective when I help weigh in on the need for antenatal steroids is in patients who seem to be decompensating from a cardiovascular standpoint, who I feel need to be delivered early because of their cardiac disease. So I'm going to defer that one.
Es muy importante la atención preconcepcional para prevenir complicaciones, especialmente en mujeres con problemas cardíacos previos. También excelente ponencia, mucha información valiosa en temas que aún son controversiales. Y en este mensaje tenemos varias preguntas. La primera es sobre, en nuestro país, algunos médicos consideran que la metformina no es segura durante el embarazo. ¿Qué nos podría comentar?
Okay, so I have a question here. First, he read some comments that they were congratulating you on this talk. It was really good. Next, it was that in our country, some doctors consider that metformin is not safe during pregnancy. What can you tell us about that?
So again, that's a little bit more of an obstetrical.
Eso es una pregunta siempre un poco más obstétrica. Lo que yo diría es que en Estados Unidos sí nos sentimos cómodos utilizando metformina durante el embarazo y es frecuentemente utilizada. No estoy seguro cuáles son los datos para que fuera inseguro, pero sé que los obstetras normalmente se mantienen seguros con esto.
Gracias. Otra
Thank you. We have another question. So here in El Salvador, still some colleagues consider not to treat hypertension until it exceeds 160 over 110. What can you tell us about that, since we saw there is a new objective for blood pressure in pregnant women?
So I think it's important to differentiate between treating chronic hypertension and treating a hypertensive disorder of pregnancy. So it's true that for a patient with chronic hypertension, there is a more recent randomized control trial changing the blood pressure goal from that traditional recommendation because there was no difference in fetal outcomes, but there was improved maternal outcomes, including a lower rate of preeclampsia with severe features during pregnancy. When obstetricians are treating a hypertensive disorder of pregnancy, on the other hand, they do tend to allow or permit higher blood pressures because there is concern that if one treats the blood pressure, they may be masking progression to preeclampsia with severe features that would require specific treatments to prevent the progression to life-threatening eclampsia. So without knowing more of exactly the situation that you're referring to, my message would just be that the blood pressure treatment goal in pregnancy is not the same across all hypertensive disorders, and that the treatment goal is different for chronic hypertension compared to hypertensive disorders of pregnancy like gestational hypertension or preeclampsia.
Siguiente pregunta. ¿Qué opina de los SGLT2 en la miocardiopatía periparto aún con glicemia normal?
Even with normal glycemia.
That is $1 million question. So we are still in the process of trying to understand what are the best medical therapies to optimize outcomes for peripartum cardiomyopathy. SGLT2 inhibitors are currently not approved for use during pregnancy and should be used with extreme caution. And in fact, I would err on the side of not using during breastfeeding because there is just an absolute paucity of data. Once patients are done breastfeeding, I will typically start them on all of the guideline-directed medical therapies that would be indicated, irrespective of the fact that they have peripartum cardiomyopathy versus another kind of non-ischemic cardiomyopathy. However, at this point, the data for the use of SGLT2 inhibitors, specifically in peripartum cardiomyopathy, in my opinion, is not strong enough to recommend that a patient stop breastfeeding just to start the medication.
So we have one last question. It has been a lot today. So what is the best echocardiographic predictor of complications in patients with obstructive sleep apnea and pregnancy?
You know, I'm not aware that that specific question has been studied, although it's a very interesting question to look into. In general, echocardiographic features including left ventricular hypertrophy, ventricular dilation, ventricular dysfunction, and atrial dilation are most strongly associated with complications such as heart failure and arrhythmia.
Muchas gracias. Tenemos una pregunta más sobre un caso. ¿Cuál es el pronóstico de un feto y la madre cuando la embarazada, desde el inicio del embarazo, presenta presiones arteriales de difícil manejo? 210/140. ¿Debería hacer un estudio más exhaustivo con este tipo de pacientes de difícil manejo? ¿Cuáles serían los estudios a indicar?
So another question appeared, and this one is, what is the prognosis for a fetus and the mother when the pregnant woman presents difficult management of blood pressure with a blood pressure of 210/140 from the beginning of pregnancy? And also they ask, should we do more studies with this type of patients? Which studies?
Interesting. So yes, the prognosis is worse for baby and mom in the setting of poorly controlled chronic hypertension during pregnancy. That would be chronic hypertension because the patient is presenting before 20 weeks of gestation with severe range blood pressures. Adverse outcomes are most likely related to the chronicity of or duration of severely elevated blood pressure during pregnancy. So for that patient, if she could quickly be optimized and achieve closer to goal blood pressure, outcomes would be expected to be much better than if she continued on having resistant and poorly controlled hypertension. So at that point, all is not lost. The baby should be assessed to make sure baby is okay despite the very elevated blood pressure detected. But as long as the patient can work with her healthcare team to get her blood pressure under control, her outcomes could be okay. She's certainly at increased risk for preeclampsia, even if her blood pressure is at goal, and other cardiovascular complications associated with chronic hypertension. But the goal should be to optimize her blood pressure. As far as studies go, I think it's wide open, honestly, as far as things that we need to learn in order to optimize risk factors to prevent or reduce the risk of cardiovascular conditions acquired during pregnancy. As I referenced in my talk, we have guidelines to suggest the treatment goals for these risk factors to address sort of overall pregnancy outcomes. But when we're thinking about what are the goals of treatment to truly optimize the risk of these cardiovascular complications, we don't really know at this point. So I think really trying to understand what the treatment goals should be in order to reduce the risk of these cardiovascular complications that are associated with significant maternal and fetal morbidity and mortality would be a great place to start.
Muchas gracias, doctora Goldstein, por dedicar este tiempo.